discussion of Stephen King's Gerald's Game. So we're going to kind of run through this the same way we would have if I were physically present on the service today. So again, thanks everyone getting or adjusting your schedule to log in. Where would you like to start? Any opinion as to what part of this movie you may have found interesting and wanted to discuss? Some audio problems, technical difficulties on your end? No worries. Hang in there.
We're just trying to make sure that there's no feedback.
Sounds good here.
And that everyone can hear. So
you're good?
I think we got it sorted out though.
Okay, you're good to go.
One of us is going to unmute so that there's no echo.
That'll work. All right. Any character, any scene, anything from this film strike you as meaningful from perhaps a behavioral or psychiatric perspective?
I think just to start off, the discourse between her own hallucination of herself and then her husband is very interesting, and they're kind of sometimes at odds, sometimes seemingly to help each other, and sometimes feeding into her just like psychosis as well. So it's interesting to hear what her self-image has to say versus what the husband does.
Yeah, and I think from that perspective, it's worth kind of reviewing one way in which a clinician, even an individual, may interpret auditory hallucinations. So I think, first and foremost, and we can actually pick C both, but when we see films depicting what this film actually shows, and that is her talking to herself, we have to decide whether she is truly experiencing a visual hallucination or whether it's an auditory hallucination and it's the writer-director's prerogative to demonstrate that, to illustrate that the way they have. And there's no right answer. But I think if we kind of investigate each, we might actually generate a differential. That is, there might be etiologies that result in auditory hallucinations that differ from those that generate visual hallucinations. And I don't think what we observe in the main character in Gerald's Game is definitive. I think it's up for interpretation. So that's number one. Inasmuch as we might think this is an auditory hallucination, if we just go down that path first, your observation, I think, is right on. And that is, individuals with auditory hallucinations may be along a continuum. And this might be a little bit of an oversimplified approach, but we all have thoughts. And we all have thoughts that are not allowed to come to conscious awareness. These are impulses, right? So maybe they're not truly thoughts, but impulses that are simply not allowed to come to conscious awareness. Those impulses are housed in the id, in our subconscious, and yet another part of our subconscious, coined the superego, is that component of ourselves that serves as a filter. That is the part of our personality that does not allow these taboo thoughts, feelings, and impulses to come to conscious awareness, come to the cortical level. Through various mechanisms, an individual then generates thoughts, and then at a level even beyond that, may get to a place where they don't even recognize that the thoughts are a product of their own mind. Right? There's a form of dissociation between what they experience as a sense of self and their thoughts. In that sense, that process is coined psychosis, and specifically the auditory hallucination. So from this general perspective, an auditory hallucination is a thought that through various mechanisms is experienced as coming from outside of one's head. And you'll see this in clinical practice fairly often, where someone will present with a chief complaint and the clinician may consider an auditory hallucination. And one of the fairly routine follow-up questions is, do you recognize the thought as a product of your mind or not? And then that really helps kind of delineate whether or not it's just a thought, perhaps an intrusive or obsessive thought, which would kind of guide you towards one set of disorders, or whether it's a psychotic process, an auditory hallucination, which of course would then allow the clinician to formulate a differential diagnosis that would include an entirely separate set of chapters in the DSM. And we kind of see that play out here. These are her thoughts, but she's losing her grip on reality. And the question is why? And the answer to why for this film can easily differ from film to film, from patient to patient. Right? These are varied reasons, and we can explore those that we think present in this film. Questions? So,
in terms of potentially her thoughts being externalized via these hallucinations, what then is the space for why her hallucination of her husband seems to not have a full picture of her, she is revealing things to that hallucination, despite the fact that if it's coming internally, it should know just as much as she does.
Right. So what this particular character thinks of herself might be unduly influenced by the opinions of others. And I think that's what might be represented in the auditory hallucination, depicted or illustrated by her husband, if that makes sense. And I think there's something to that, because when you look at this character a little deeper, that is, those elements and factors that predispose to the behavior that we observe, we do understand that she has struggled with her self-identity and has had her identity unduly influenced by others, not only her husband, but of course her father. Right, so there's something to that. Did I answer your question? Okay. So, any observation, any thoughts, pardon the pun, of why this character is beginning to, again, we could state this in a couple of ways, either lose her grip on reality, so we see behavior that is no longer reality-based, and or is having difficulty appreciating that her thoughts continue to be a product of her mind.
Well, for one, I remember the scene where she, as her older self, goes kind of back in time to talk to or be present with her younger self during the eclipse. So she's experiencing, as her reality, a different time.
You're right. Why? Obviously, these are thoughts that she's been carrying with her, and only now are coming to conscious awareness. So she's repressed them. And I think we can have a basic understanding as to why. What's happening that is allowing her repressed thoughts, her repressed memories, to come to conscious awareness?
Is it her physiologic compromise and the fact that she is dehydrated and changed to a bed, through that trauma?
I think dehydration is the single best answer. Yeah. So what's happening here is that we have an insult, specifically dehydration, that is adversely impacting the cerebral cortex. And when that happens, and when the individual, any individual, loses that protective mechanism of the cerebral cortex, well, the subconscious tends to become conscious. Now again, the cerebral cortex can be stunned through various mechanisms. It could be due to the direct physiologic effects of a substance. I'm not sure if substance really plays a significant role in Gerald's game. Or it can be due to another medical condition, which dehydration, I think, serves as a very good example here.
I also wanted to comment. Sorry, there's an audio issue. One sec. I wanted to comment too on the fact that, like, when she sees the Moonlight Man in the corner, like, that's the one thing that actually is real in the room. But she, like, immediately assumes that's a hallucination, whereas, like, the actual hallucinations she engages with and believes are real, which I also thought was interesting.
Yeah. Any thoughts as to why?
I think it is part of like the recurring theme of how she processes trauma, probably due to how she would like burst out with her initial trauma during the eclipse, which is that she tends to deny and run away from those things. I think that's part of what triggered her own like reaction to her husband's death, because obviously she wasn't acutely dehydrated as soon as that happened, and yet she had her psychotic break pretty quickly after that. And then if the real thing is now the Moonlight Man in the corner, instead of turning it into a reality for herself, the runaway coping mechanism would be to then turn it into a hallucination.
Yeah, and it is nice to link each of these hallucinations, each of these perceptual disturbances to her past, and what she is giving emotional valence to versus those that she is not empowering. And I think there is something there. She, quote, married her father, end quote. That is a significant theme in the novel. It is a significant theme in this adaptation. And to that end, she believes that her husband's image is real. Right? Moonlight Man, not really sure where this is coming from in terms of what emotional valence she will attach to this. But certainly I think it's reasonable to assume that it's not nearly as intense as what her husband symbolizes and illustrates.
I also feel like in a more superficial way, like he doesn't look traditionally human because of his acromegaly and everything. So I think maybe in that setting it would be easier and maybe less scary for her to think that he is a hallucination instead of thinking like, oh, there is someone in the room who looks like that and could hurt me.
Yep. Good. And I like that idea too, because what that discussion kind of brings us to is a more kind of clinical element and explanation to this. Now, not that linking her experience to her past and traumatic experiences isn't scientific, but we're coming from a little bit of a different direction with this. And I'd even take it one step further, and that is there may not be too much, or maybe we shouldn't read that much into why one but not the other, only to identify that her interpretation, real versus not real, appears to wax and wane. I just don't want to skip over that premise, which I think everybody here automatically identified and went even beyond to begin to explain why we are seeing this behavior wax and wane. And I wanted to bring that up because we have a condition, we have a scene, we have a film that demonstrates perceptual disturbances in the context of episodes that wax and wane. So to this point in our film discussion, what illness might our main character be struggling with? As a result of dehydration.
Delirium?
Yeah. Yeah, I think delirium would be at the top of our differential diagnosis. I don't see, I may have missed her having any past psychiatric history, so I'm not so sure I would feel that comfortable discussing a psychotic disorder that is a mental disorder from the schizophrenia spectrum and other psychotic disorder chapter of the DSM. This seems to be abrupt in onset. It seems to wax and wane. Again, she's got lucid, let's say, when it comes to the Moonlight Man, and yet a change of consciousness or altered consciousness when interacting with both her and her husband's images, visual hallucinations versus auditory hallucination. So it really does. That is, Gerald's game does appear to shape up like a fictional case of delirium. Now, are there any additional elements that support delirium as the single best answer? So I'm taking the radio silence as not obvious. Different direction, a little bit of a different perspective. What is necessary for the diagnosis of delirium? And then the question we will ask off of that is, are those elements contained in this film? So delirium has a three-part definition, conforming to the 3 C's. Anyone want to offer what the 3 C's defining delirium are?
Is one confusion?
Yeah, right. So there are deficits in concentration or cognition, more specifically. The individual must demonstrate 2 or more, one of which must be concentration/attention. Right. So that does seem to be in play here. There are 2 other C's that define delirium.
Altered level of consciousness?
That would count towards cognitive deficit, yeah. Mm-hmm. Number 2 would be the course. The course is defining. If an individual presents with 2 or more deficits in cognition, but their course is slow in onset or gradual in onset and progressive, you're not probably then seeing a case of delirium, right? That looks like another neurocognitive disorder, perhaps major neurocognitive disorder. That would be in a differential diagnosis. But this course seems to be acute in onset and fluctuating, as we had mentioned, and inasmuch fits that second criterion of delirium. And then finally, the third is not only is it important for exam purposes, but it's also critical in clinical practice, because that third C is the cause. And once we focus on the cause of all of the above that we discussed up until this point, we realize that delirium is not a true mental disorder. Delirium is a behavioral manifestation of an underlying medical or neurological condition, and or the direct and physiologic effects of a substance, which is the complete opposite of any mental disorder published in the DSM-5. Right? For every other mental disorder, whether it's in the psychotic disorder chapter, anxiety disorder chapter, etc., the clinician must first investigate and rule out that the condition isn't due to the direct and physiologic effects of a substance and or another medical condition. So this is just the reverse, and therefore it's not a true mental disorder. So that's the clinical pearl, and we have to be very careful about that. We know that...
Sorry, I just had a question about diagnosing her and like the clinical timeline of everything, because I feel like none of us would argue that she's already kind of dealing with PTSD in her own right prior to this whole episode. And then if we're defining this episode as delirium, then is her ongoing hallucination of the Moonlight Man in her home afterwards a continuation of that, or is it a new episode triggered, like a new set of PTSD offshooting the trigger of this instant?
Okay, so let's take the answer to that question in a couple of steps. Number one, from the film's perspective, I want to poll the audience. Choice A, the answer to this question is straightforward and described in the film, or B, actually, let me take it this way. It is straightforward, and the answer is that it is an enduring symptom of PTSD. Choice B is that it is obvious and appears to be part of delirium. Or C, neither of the above. It's not obvious. Thoughts? So you can put it. I mean, if you don't want to unmute, feel free to put your answer A, B, or C. It's obvious in the chat room. It's obvious and it is due to PTSD. It's obvious and it is due to delirium. Or C, it's not obvious. It's left ambiguous. Okay, so we're getting a bunch of C's, right? And I would agree. Okay, and again, welcome to the field of psychiatry. When you are put into this area in a clinical situation, what is the next best step? What answer do you have? How do you want to proceed? Do you want to choose A or B? And the answer is that you choose B, because you're going to be loyal to the American Psychiatric Association guidelines, that it's always due to an underlying medical condition or the effects of a substance until proven otherwise, and that is delirium. So my answer to you is it's delirium, because I don't know what it is. And it's safest, do no harm, to proceed as if it were delirium. Now, if we're wrong, there's going to be some unintended consequences. However, if we went in the other direction and we were wrong, those consequences are likely to be significantly more severe. So from a clinical perspective, since it is ambiguous, I'm going to proceed as if it's an enduring delirium. What is the other role that post-traumatic stress disorder plays in this movie? It's a predisposer to delirium. Individuals who are admitted into a hospital for X, whether it's a surgery, etc., may or may not experience episodes of delirium. Whether they do is likely the accumulation of multiple risk factors, including number of medical comorbidities as well as age. Those are the two that we often think of. But another one another category or another risk factor that would predispose would be a past psychiatric history. So post-traumatic stress disorder likely plays that role. Remember, when we begin to formulate human behavior, whether normal or abnormal, we look at predisposing factors, precipitants, and perpetuating factors. This movie, I think there's a predisposing factor, and I think that's her post-traumatic stress disorder, which appears to have gone untreated. The precipitant is going to be the dehydration. And to the extent that we understand the Moonlight Man visiting her at the end of this movie, I'm wondering if there are perpetuating factors also in play. And I'm not sure if I identified those, but if she, at the end of this movie, or in the sequel, were to present to us with that chief complaint, I would think a focus of our treatment planning would be to identify those potential perpetuating factors. Questions up to this point? All right, so let's focus a little bit more on our patient's condition. And first ask if we identify any additional causes, that third and final criterion for delirium, beyond the dehydration? I think the first step would be for the group to tell me what the causes are, and then we could look at that short list. Well, maybe not so short list, and determine whether or not they're actually in the script. So before people, actually, you know what, instead of unmuting, because again, it's not such a short list, why don't we put it up in the chat room? Different causes for delirium. Excellent. I'm not going to read them out loud, just reviewing them as they're being put up in the chat. All correct. All causes of delirium. Perfect. Perhaps just as importantly, also, well, chat room, or if you're bold enough, sure, feel free to unmute. Your favorite Shakespeare play? I'm sorry, I missed that. Midsummer Night's Dream, good. Othello, Romeo and these I will say out loud. Romeo and Juliet. Taming of the Shrew. Did you like it? Hamlet. There's no psychiatry in there, huh? One more? Just one more. No? We're done. All right, so that's good. Unfortunately, nobody got it right. Not that your own opinion isn't the right answer. What I was looking for is Macbeth, the tragedy of Macbeth. Anybody here, although it's not being your favorite, ever read the tragedy of Macbeth? We have a few. All right, so I'm not going to give you the synopsis, and I surely didn't assign anyone to read Macbeth. But a basic understanding allows us to kind of revisit what happens in the tragedy, and focuses primarily on the character of Lady Macbeth. Because after the, spoiler alert, assassination of King Duncan, we have Macbeth ascending to the throne of Scotland, and soon thereafter there is what I would argue the most infamous scene in all of literature, and that is Lady Macbeth's quote, "Sleepwalking," end quote. Anybody here remember that scene? So again, several nods of the head, yes. Out, damn spot. Okay, now if you take a little bit of a closer look, that scene, of all things, a physician is up in the middle of the night and observes Lady Macbeth sleepwalking. And what the physician says, for us, would quickly identify that she is in fact not sleepwalking at all. She's got mumbled, incoherent speech. She's got bizarre behavior. What is it that she has, if not sleepwalking? Yeah, absolutely, 100%. The tragedy of Macbeth is similar to Gerald's game, and this might be the only didactic that actually states those two works in the same sentence. Similar to Gerald's game is a story, is a fictional case of delirium. So why bring up Macbeth and link it to a Stephen King novel? And that's because the acronym of all of the etiologies of delirium would include I Heart Lady Macbeth. So everything you listed in the chat room fits here. Okay, so taking them one by one. Immunologic, right? So there are immunologic causes. The two that come to mind quickly are exacerbations of SLE, SLE cerebritis, as well as anti-NMDA receptor encephalitis. Those are the two that come up on exams quite often. Heart, obviously focuses on the cardiovascular system. Individuals who present with an acute MI can present as delirium. Yes, thank you. All autoimmune encephalopathies, including CJD. Good. Yep, exactly right. Lady, L-A-D-Y. L, lumbar puncture. A, arterial blood gas. Now, if your pulse ox is 100%, you're not going to get an ABG. But the idea is hypoxemia. D, drugs. All right, so the impact of drugs. Illicit, both intoxication and withdrawal states. Licit, prescribed, anticholinergics, drugs. And the why is tricky, the why nobody ever guesses, but once you hear it, you never forget it, and that's yaws. I'll put it up in the chat room, that's YAWS. This is a spirochete infection. So when you think why, when you think yaws, you think neurosyphilis. In 2022, if you think neurosyphilis and you're thinking of working up a patient with abrupt onset of delirium, you're also going to get HIV serology. Macbeth, M, malignancy. A, ammonia, so hepatic encephalopathy. C, there are a few C's. Number one is a complete blood count. So everybody here mentioned infection. And along those lines, complete blood count links with the urinalysis. C also stands for comprehensive metabolic panel. And then finally, a third C, ceruloplasmin. So the screening test for Wilson's disease, especially in someone who's young. B vitamin deficiency. All right, so niacin, pellagra. Thiamine, Wernicke's-Korsakoff, as well as folic acid and B12. B vitamin deficiency. E, EEG. EEG can be diagnostic, so individuals can be in non-convulsive status. It could also be supportive, that is the non-specific finding of delta waves, delta slowing, right? Diffuse cerebral dysfunction. Very non-specific, but consistent with delirium. T, TSH. T also stands for trauma. And then the final letter, hypertensive encephalopathy. H also stands for head CT or MRI. And one more H, heavy metal poisoning. So, may have missed one or two, but otherwise, I Heart Lady Macbeth really does allow for remembering several of the etiologies of delirium. Questions? All right, so medical students are asked to evaluate a patient with agitation after a bedside psychiatric interview, including a mental status examination and perhaps even a MMSE. You believe the single best answer is delirium. And now you're asked about the etiologies. Very infrequently would that answer be I Heart Lady Macbeth in totality. You're not going to get every test for every patient every time. So we need to figure out the way in which we're going to go through thinking about these different potential etiologies. So first and foremost, we are going to investigate anything that appears to present through the history or physical exam findings. That's pretty obvious. So if there are H&P findings consistent with any of these etiologies, please pursue that etiology. I think that's very straightforward. Matter of fact, for a consult team, that's usually already done, right? The primary team has already tackled that one. But that's always the first step. When psychiatry is consulted about agitation, delirium, it's usually in the patient that is not giving the answer away. So the H and P is equivocal. Now what? Well, step one is always remember your ABCs. Right. So your first set of tests would be vital signs. Of course, already done in clinical practice, probably not done on a shelf exam. So ABCs. Vital signs would look at hypoxemia and hypertensive encephalopathy. So you get the A and the H. A for ABG, the H for the hypertensive encephalopathy. Circulation would also include the EKG. So step one would be remembering your ABCs, and that would cover at least 3 from the list of I Heart Lady Macbeth. Again, that would include hypertensive encephalopathy, ABG, and EKG. Next, always consider the impact of drugs. Always consider the impact of drugs. Drugs, especially during selected withdrawal states, might be life-threatening. So that might be step 2. That's going to include a very thorough review of the patient's current medication list, as well as any potential withdrawal states of illicit substances, or even prescribed in the sedative hypnotic class. So always think through the impact of drugs. Step 3. Step 3 is what we usually refer to as the routine delirium labs, right? And I believe there are 8 of them, right? So CBC, and remember I said anytime you think of CBC, that's UA. The Comprehensive Metabolic Panel, the TSH, B12, folic acid, RPR, and HIV. That would be step 3. Not quite yet. Not quite yet. It's quite all right. Step 4, EEG. Head CT, and pneumonia. And then finally, the 5th and final step, as I'm going through these steps, obviously, it's when the results come back and are normal. When step 4 has been completed, when you get the EEG and it only shows the diffuse background slowing, head CT, no acute changes, no acute findings, ammonia level within normal limits. Step 5, 5th and final step, is everything else.
Dr. Novia, if the EEG showed diffuse swelling, would you still need the head CT or no?
So I got the first part. I didn't hear your question about the head CT.
If the EEG showed you the diffuse swelling, would you still need a head CT or no?
Yes, because what you're looking for diagnosis. You're looking for something in the imaging that would lend to the etiology of the delirium. The EEG, the only time the EEG does that, well, not the only time, but the most common finding on the EEG that would lend to an etiology would be seizure, right? Non-convulsive status. In the absence of that, and the baseline finding, the only finding being the diffuse background slowing, well, that just supports the delirium, right? So that's diffuse cerebral asynchrony. So that's not causing the delirium. The delirium is causing that. So with that, yes, you want to get that CT or MRI, depending on your clinical index of suspicion, to look for the cause. Questions about the workup? So getting back to our fictional case, is there anything in this film to suggest anything from this list beyond the dehydration? And by the way, dehydration, of course, is loosely associated with the comprehensive metabolic panel, right? For example, hyper or hyponatremia, that of course depends on whether your patient has access to free water. Our patient does not, so her serum sodium may have been greater than 150. All right, and then treatment. Talk a little bit about treatment. So number one are non-pharmacologic parts of the treatment plan, usually referred to as the delirium protocol. All right, so we want to really focus on grounding the patient even when you're not at bedside, making sure they understand where they are, when it is, and that even goes into daylight versus night. Along those lines, it's very important that you and medical staff always introduce yourself and reorient upon entering the room. This is even done when we're outside the room. The boards in those rooms are written on with much larger letters than usual. We strongly encourage family be at bedside. We strongly encourage that family bring in objects that are familiar to the individual from home, especially pictures that we keep up at bedside. So all part of what is referred to as the delirium protocol. We try to limit ambient noise, right? So no chatting outside of the patient's room, so they're not disturbed or distracted by external stimuli that they can't see. We try to keep the room lit, consistent with the day-night diurnal variation. So we do not turn every light on at 1 or 2 o'clock in the morning, and we try not to keep the room dark, lights off, curtains closed at 1 or 2 o'clock in the afternoon. We try to adhere to a no tether policy, so remove Foley's unless otherwise clinically necessary. All part of the delirium protocol. Again, fortunately or unfortunately, by the time a psychiatry consult team is requested to provide an assessment, that's already been tried and unfortunately has been unsuccessful. Because if it was successful, psychiatry would not likely have been called. So by the time we get to see the patient, the primary reason for consultation is the next step, which is the pharmacologic management of delirium. And if that has happened, frequently what has also happened is that there's some form of agitation or combativeness that needs to be addressed. The literature on prophylacting in a state of delirium is right now not universal. There's some studies that certainly support the use of medications from the antipsychotic class. And then there's certainly emerging literature to support that the risk-benefit is not conducive, and therefore medications, antipsychotics, should not be provided in a scheduled manner that is around the clock. I think what we often do as a team, what I do, is provide it as needed. And if frequent PRNs are required, the patient's telling us, albeit not verbally, that the PRN scheduling is not working. And at that point, instead of observing the behavior and providing a medication for that behavior, such as combativeness, we need to get ahead of the curve, and we need to switch from a PRN schedule to a time contingent one, around the clock dosing. Medications universally used are from the antipsychotic class. And when first prescribed PRN, we usually will document to provide as needed for agitation that either impedes essential medical care or places the patient or others at risk. So danger to self or others, or impeding essential medical care. These medications are not without side effect. Individuals who have delirium are often medically compromised, usually multiple medical comorbidities certainly place the individual at risk for, if not are causing, the delirium. That also means that the same patient population are going to be susceptible to medication side effect. So cardiopulmonary would be our major concern. These medications are classified by the American Heart Association as agents that can induce arrhythmia. So you're worried about the QT interval, and you are worried about the risk factor of a ventricular arrhythmia called torsades. So we monitor the EKG. Whether you monitor it daily, individual with established coronary artery disease daily, or less frequently, people who might just have risk factors but not heart disease or an equivalent, is attending dependent. That's something you'll discuss with your attending, whether you want daily EKG or less frequent monitoring. It has everything to do with coronary artery disease as well as one's risk for heart disease. Additionally, we usually ask that the electrolytes be closely monitored because we want to make sure that we are addressing any other risk factors for QT prolongation. Right? That includes derangements in sodium, potassium, magnesium, and chloride. So, I mean, if people have hyponatremia, hyperkalemia, hypercalcemia, etc., they're just additional risks that are going to be cumulative along with the antipsychotic medication. So, close monitor of electrolytes, and of course, correct any deviation from normal. Questions at this point? Delirium, we only have 10 minutes left. I'm not going to get into alternative medication therapies, medical therapies for delirium. We'll talk about that on service. That is taken by the proverbial case-by-case basis. The antipsychotics are universally prescribed. However, there will be situations in which they'll be unfortunately contraindicated. So if someone with an established prolonged QT interval, or perhaps was placed on one of these medications and has then had prolongation of their QT, usually we begin a sincere risk-benefit discussion, probably not with the patient because of their delirium, but certainly the family, the primary team, and maybe even a consulting cardiologist. Risk-benefit at or around 480 milliseconds, certainly by 500. The other parameter to keep your eye on is a 25% increase over baseline. All right, 10 minutes to go. Any final questions? All right, I'm going to post it on Twitter for you, but next week's discussion, which will be in person, next Friday's discussion at noon will be the skeleton key. So we'll tackle a group of disorders through film analysis of the skeleton key next Friday. If there are no other questions, I want to thank everybody for joining us today.
Thank you.
Thank you.